Thank you, Mr. Chairman. I will be highlighting certain aspects in the guidelines for the optimum medical management of acute iliofemoral DVT. Let's first share with you some of the clinical case scenarios of iliofemoral DVT. A patient, 22 years old athlete with a history of factor V Leiden mutation, a 46-year-old woman with advanced ovarian cancer, 32-year-old woman with intrauterine fetal death on hormonal therapy, and an old man with a recent history of hip replacement. We all agree that these patients have different management plans. So for the optimum medical management, we should answer these guiding following questions, starting from which patients require initial home treatment versus hospitalization, and ending with what are the updated indications for IVC filter insertion. This is based on the guidelines from the American Society of Hematology and the European Society for Vascular Surgery 2021. We all know that the DVT treatment options include anticoagulation and early thrombus removal. The anticoagulation has three phases: initial phase, principal phase, and extended treatment phase. Answering the first question, which patient require initial outpatient treatment versus hospitalization? Since the introduction of the low molecular weight heparin and DOACs, increasing numbers of patients were treated at home, and the EVSC recommended that most patients with deep vein thrombosis outpatient management is recommended. So which patient require hospitalization for the management of deep vein thrombosis? Indications include patients with limb-threatening DVT, like 𝗓𝗂𝗋𝗀𝗀𝗃𝗀, patients at high risk of bleeding with recent surgery, patients at risk of PE, contraindications for anticoagulation like active bleeding, other comorbidities like cardiopulmonary instability, medical non-compliance, as well as social circumstances not supporting home treatment. So what hospitalization offer more than home treatment? Intervention procedures like catheter-directed thrombolysis, pharmacomechanical thrombolysis, surgical thrombectomy and fasciotomy, IVC insertion, management and control of those at high risk of bleeding, institution of intravenous fluids, analgesia, unfractionated heparin for certain subgroups. Next, which patient could be offered thrombus removal strategy? As my colleague mentioned, most of the patients are treated conservatively, but in selected patients with symptomatic iliofemoral DVT, early thrombus removal strategy should be considered. These indications include patients with limb-threatening DVT, like 𝗓𝗂𝗋𝗀𝗃𝗀𝗃, selected young patients with symptomatic iliofemoral DVT with low risk of bleeding. Which antagonist should be used for the principal treatment phase? DOACs are indicated for both provoked and unprovoked patients, and are recommended over vitamin K antagonists and the low molecular weight heparin. But this recommendation may not apply for certain subgroups, including renal insufficiency, antiphospholipid syndrome, extremes of weight, and the cancer patients for which other products are used. Is there a role for unfractionated heparin? Yes, in patients with planned invasive procedures, recent major bleeding episodes, severely impaired renal function, hemodialysis, and extremes of weight. What is the duration of the principal treatment phase? Multiple trials have compared 1.5 months versus 3 months versus 6 months, and it was found that 3 months have the best VTE recurrence prophylaxis and with less side effects like bleeding risk. So for the principal phase treatment, 3 months is indicated for both provoked and unprovoked, whether proximal or distal DVT, and whether transient or persistent risk factor, it's 3 months. So what are the indications for the extended phase treatment, more than 3 months? This depends on the risk stratification of VTE recurrence. So we have high-risk patients like active cancer, severe thrombophilia, and the chronic rheumatic disorders, and the medium-risk patients like recurrent venous thromboembolism and unprovoked event. Those need extended anticoagulation. What are the therapeutic options for extended phase anticoagulation? We compared aspirin, vitamin K, and the DOACs, and it was found that aspirin has a very low VTE recurrence relative risk reduction, 38%. So no role of aspirin for the second prevention. We use the vitamin K antagonists and the DOACs. What is the dose and the duration of DOACs for the extended phase anticoagulation? This again depends on the risk stratification. For the high risk, the duration is indefinite, and the therapeutic dose of DOACs is used, while for the medium risk stratification, the duration is equivocal from 6 months to 2 years, and the prophylactic dose is used for the DOACs. What is the role of D-dimer and duplex ultrasound for the extended duration? While the American Society of Hematology suggested against the routine use of prognostic scores, D-dimer and ultrasound, DSVS recommendations stated that it might be helpful for the detection of the duration of anticoagulation. When is ambulation exercise safe after acute DVT, and what is the evidence? 4 randomized controlled trials were examined to answer this question, and it was found that early ambulation has no risk of pulmonary embolization or thrombus propagation. On the contrary, it decreases acute limb pain and edema, so it suggested that ambulation is safe in patients with acute DVT after the achievement of therapeutic anticoagulation. Is it safe to use compression therapy for acute DVT, and when? Multiple studies have examined the use of compression therapy for acute iliofemoral DVT, and it was found that early compression leads to significant reduction in pain with swelling and improvement in clinical severity score, significant reduction in incidence of reversible skin signs and improvement quality of life, as well as a reduction in the amount of residual vein obstruction, but has conflicting results as regards the role of compression therapy in preventing PTS. Is it safe to use the compression therapy? Yes, it's safe, and it doesn't increase the recurrent thromboembolism. The timing is applied within 24 hours of the diagnosis. It leads to decrease the pain, edema, and residual venous obstruction. What is the length of the stocking? There is no difference between below the knee stocking or above the knee stockings. The duration depends on Villalta score. If less than 4, you can stop the compression, but if Villalta score more than 5, you can use it more than 1 year. Contraindications, peripheral arterial disease and the congestive heart failure. What are the updated indications for IVC filter? The main indication is contraindication to anticoagulation. Some studies showed that panelists advised against IVC filter insertion for patients with recurrent VTE, and also against prophylactic use of IVC filter without the presence of VTE. What are the indications of thrombophilia for testing in patients with acute DVT? Not all patients need thrombophilia testing, only in unprovoked DVT in young patients less than 40 years, strong family history, thrombosis in unusual site, female patients with DVT and recurrent miscarriages or recurrent VTE. The timing is not used in the acute phase and is done after receiving the anticoagulation, 2 weeks after the vitamin K antagonist and 3 days after the DOACs. So having said that, and turning back to our clinical case scenarios, it should be a personalized approach. For the 22-year-old patient, he has thrombolysis and long-term anticoagulation. For the 46-year-old woman with advanced cancer, she needs only low molecular heparin plus or minus thrombectomy. And for the young lady, she needs no longer-term anticoagulation. For the old patient, he has only DOACs and compression stocking without thrombolysis. So my take-home message is that one plan doesn't fit all. Management of DVT should be individualized. And thank you for your attention.